go to the next presentation. Dr. Ang from the Philippines will present his paper on the EVO. Thank you.
Good morning. Thank you for having me in this STAR Symposium. So my talk is about from exception to everybody, my approach to EVO ICL offering. So I'm an investigator for STAR Surgical as well as other companies. So in my private practice, so we practice in Manila, the Philippines, and we have 2 surgery centers and 5 satellite clinics. And my role there is cataract, refractive, glaucoma, and cornea. And so far, over the past 25 years, I've been doing LASIK, PRK, ICL, and I've had the fortune of participating in these pilot studies of the Viva ICL. So, like others, 20 plus years ago, we bought our excimer laser and we started practicing LASIK and PRK. And we were happy. We learned and accepted the limitations, the outcomes, and the problems associated with LASIK and PRK. We also learned that higher treatments or deeper ablations can cause ectasia, induce aberrations. So better diagnostics over the years helped us detect these suspicious corneas. And another thing that we notice in our practices is more and more kids now come with higher myopia. 20 years ago, it's usually -3, -4. Now, when they come teenagers, they're -7, -8. So higher and higher myopes are coming to our clinic. So just like most of us, our ICL use was, if they're not qualified for LASIK, that's when we offer ICL. So those were beyond the range of LASIK, or they had thin corneas, irregular corneas, insufficient stromal bed. That's why we introduced ICL. It wasn't a first-line offering, but you're not qualified, we have something else. So at that time, our ICL was limited to the highest of myopes. So we put together some of our outcomes, and whether it's LASIK, PRK, or ICL, the MRSEs were very, very good, very similar in terms of efficacy. In terms of UDVA, they were good enough because the high myopes also had good uncorrected distance vision, just like your LASIK and PRKs. So one of the things that we track over time is safety, and safety means 2 things. Number 1 is your IOP. You shouldn't get a spike, whether in the immediate or late post-op phase. And we watch the endothelial cell count. So whenever they come once a year, I would do a specular microscopy. And we see that aside from the initial trauma of the first surgery, they were stable. So it gives us good confidence that the lens can stay there basically forever. So spherical aberration-wise, we know that the higher treatments cause induction of positive spherical aberration, whereas if you don't touch the cornea, then more or less you're safe and stable with untouched or basically minimal change in spherical aberration. So early experience with the ICL was in high myopia. They were very good, reliable, and now I can treat somebody from -1 for LASIK PRK all the way till -18 for ICL. But over the past early years, so I started maybe 13, 14 years ago, and I was still careful and selective because number 1, you had to do a YAG-LI. So some patients, why are you going to laser me? I thought I was not a candidate for laser because they don't know what's the difference between YAG and LASIK. No? Next is you want to watch for early cataracts because the early papers were quoting cataracts as one of the early side effects. And next is, even though there were publications about ICL sizing and STAR will help you, you had to kind of figure out yourself because the sizing protocols were mostly Caucasian eyes. I would actually read up on the Japanese publications because they were closer to our Chinese eyes. So we were kind of hedging which method to choose. But then the breakthrough came when the Aquaport was introduced. So when the Aquaport was introduced, number 1 is it eliminated the need for YAG-LI. So I don't have to explain to them that we had to do YAG-LI before we implant. It became a one-step instead of a two-step procedure. Second is, I believe that because of the cushion of aqueous flow between the natural lens and the phakic IOL, there's a buffer of aqueous that prevents touch. So you eliminated the cataract. So those things made me and others more confident about putting the ICLs. So these are published literatures, just like Mahipal showed, that either the published literature or the FDA trials showed the same thing. The lens gave good refractive accuracy, and the UDVA was very good, and the efficacy index is exceeding 1.0, meaning the uncorrected vision is most of the time better than the pre-op best corrected vision. So in terms of effectiveness, it was good. And safety-wise, very rare. Of course, I also had my own share of uretzevalia, maybe over 3-4 cases over the past 13 years, which is a nightmare, but all of us will see that there's no glaucoma, pupillary block, pigments are not flying around the anterior chamber, and cataract is almost none. So these further increase our confidence in using the ICL long term. Because the parents of the child, the teenager in front of me would always ask, how long can this stay in my child's eye, right? So now we give them figures like some patients had 30 years ago, and when they explanted the lens for cataract. So I just tell them, when you get a cataract and need cataract surgery, that's when the lens needs to go. So now, evolution of change, just like EVO, evolution of change, because of certain factors for patient selection, you kind of know that more and more patients can benefit from ICL. So first is the myopes, so minus 0.5 to 20 diopters. Then age, because of the Viva, now the indication in the box now goes up to 60 from before it was 45. So if you notice the box, it used to be up to 45, now it's 60. Then we had two things. Number one is the ACD, at least on label now, is 2.8 because in the Philippines, many are 2.6, 2.7, not very deep, no? Very few are above 3. So even though they're myopes, they're not so deep, no? And then corneal status, of course, if they're suspicious now because of the Pentacam, because of the SCORE program, the anterior, now we're very sensitive to suspicious topographies. And any type of suspicion, you have a choice. Are you going to do KLEX? Are you going to do PRK? Or are you going to do ICL? So since I don't have KLEX, it's either LASIK or ICL. Those are the options for my patients. So first, before, only the high myopes, -6, -10, came to our clinic. And now, I offer it to even -6 below. So you see that some of my patients are even below -3. So my lowest case is -1. I have had patient who's a -1. And they all have good criteria. The second thing is the ACD, as I said, now 2.8 or 2.8 is good. Actually, when we speak to the Japanese, they go down to 2.5, but that's off-label. On-label, let's remember 2.8. No? You can use a Pentacam, you can use an Orbscan, Anterion, whichever one you have, but make sure so we don't get sued. One of them says 2.8 and above, no? Just to be sure. Now, our data shows that similar to all the published studies, 90% are 20/20 uncorrected in our patient base, and refractive accuracy is actually quite good. So it's actually more, I get more confidence with ICL than with the high myopia LASIK. So one thing that is coming,
Can I just request, sorry for that interruption, can I just request to summarize because we are running out of time.
Okay, so retreatments are an opportunity. Those that have myopic regression, we offer them ICL instead of LASIK enhancement. And we had these patients, so 10 out of the people that we want for myopic regression, we implanted an ICL. And as you can see, some of them are really below 3 diopters. Some are 1 diopter, 2 diopter. So our results show that the MRSE is as good as LASIK and PRK at the end of 6 months, and UDVAs are as good. Now, the complications are also rare. Only Volt is the worry. Lastly is the Viva. So when the Viva, we started the pilot study 7 years ago, it was a concept wherein we give them EDOF concept of an ICL for presbyopia treatment. And we did a study, 90 eyes, with toric and non-toric versions. You see that the MRSE now is on target. So we made adjustments in the nomogram so that this phase was good and stable. Stability, MRSE, and accuracy to target of the Viva and the Viva toric. UDVA was quite good, and CDVA was quite good. So about 2025 or 2020 in most patients. Now, UIVA is also very good because it's EDOF. Remember, EDOF is good distance and intermediate. Now, the near vision over time is about 2030. Don't promise J1 because they're not J1, just like your EDOF. Never promise J1. So, in summary, the ICL usage for me has grown over the years. We started from high myopes, high astigmatism. Now, the low myopes, as I said, up to -1 we use, especially for retreatments. And then we expanded now to the presbyopic age group. So, only those with shallow ACD and low spec count will be disqualified. Everything else, you can ask them and offer ICL. Thank you.
Thank you very much for that wonderful talk. And any questions? We can take Dr. Sudhang Bharti. Do you have any comment?
I think the same thing about the low myopes. I also have, wherever there is a question mark topography, I want to. So my lowest implanted ICL is 2.25. So that is the, and it's about a year back that I did, and she's doing fine. So I think we are comfortable doing ICL in a low myope also now.
Yeah. So Vardhaman, do you want to comment?
Yeah, I think I'll definitely agree with all the discussion. And yesterday only we had in a free paper presented by one of our fellows where we presented 361 eyes for people who had moderate and low myopia, ranging between -2 to -6. And we have seen excellent outcomes up to at least 1 year of follow-up, up to 2 years. I'm very sure that I think whatever the benefits and the safety we have seen for the high myopes, of course, that is going to also translate into the moderate myopes. And now we see more and more suspicion of keratoconus because the tools have become better. Because of tomography, we are able to identify keratoconus suspects much better. And that's why I think the threshold is reducing. And definitely it has worked very well in our set of patients. Yeah, thank you.